Good evening, everyone. Thanks for coming. My name is Alex Grunsfeld. I'm a neurologist. I work for Sentara, and that's pretty much my only disclosure. Other than my wife, it's the only boss I have. I don't take any money from pharmaceutical companies. They don't pay me for anything, so I have no other disclosures here. Everything I'm about to tell you is a talk about stroke. It's really geared towards the layperson, but it's based on science. The difference between a talk for people non-lay people in the medical profession and the talk for lay people who are non-medical professionals is that when I give a talk to medical professionals, I'm talking about studies. This study says this study says that, and they want to know what the different studies are telling, and I tell them what the different studies are, and it all is really opinion. Right? Because what you're going to hear from me tonight is mostly opinion based on these studies. And so that's one of the important things to know about science, is that science, many people mix up science with truth or objective realities. It's not true at all. Science is just a process. It's a method of us getting the best understanding about a situation that we can based on the tools that we have, which are not very good. And my proof that this is true, that this is the case, is every other day you're hearing something completely different than you just heard a few days ago based on newest and latest studies. So what we're going to talk about today is basically my take on what science tells us. And what's it going to be about? It's going to be about strokes, what to do if you're having a stroke, what we're going to do after you've had a stroke, and most importantly, I think, how to prevent one from happening. And while a lot of the first kind of stuff is not very controversial and not so much, there's a lot of weight of evidence for it, some of the stuff we'll talk about how to prevent it is not necessarily what you're going to hear from everyone. And so I hope that you'll hear some interesting stuff from me tonight that will make you think a little bit about what you can do to prevent a stroke for you and your kids. I think it's an important topic. Number one, 1 out of every 5 people now, it used to be 1 out of every 4 people, die from a stroke. And it's not because we're having less strokes, we're having more strokes, it's because we're better at treating strokes. But I think one of the reasons that why this story is so important is because strokes are a disease that has something in common with some of the other very frequent diseases, such as heart disease. It's a very similar problem, and we're going to talk a little bit about how that is similar. And in fact, maybe even Alzheimer's disease has similar relationships with stroke. So we're going to get into a little bit of those details to how they will come together, why this is such a big problem, and what you can do about it. So before we start with what a stroke is, let's talk about what the brain is. Okay, the brain is a mass of gelatinous material. It has the texture of tofu. It sits up here for most people. It weighs about 1.5 kilograms, around 3 pounds, between 2.5 and 3 pounds. It is by weight about 2% of the human's body mass, but takes up 20% of the metabolic work. So the brain is using up energy at a very high rate. And this becomes important when we're trying to understand why people have a stroke. So let's talk about the brain. The brain consists of cells, neurons, and then other cells around the neurons that we know something about, but there's a lot that we don't know about what they do, but they help nourish and support the neurons. We believe at this point that the neurons is where the heavy work is being done. Right now, you're not even thinking about how my mouth is moving or the fact that the sound waves emanating from my mouth hitting your ears. You're not thinking about the words. If you were maybe French speaking and you just learn English, then you would be thinking about the words and trying to translate them. But right now, automatically, those neurons are taking the words that I'm saying and turning them into meaning. So you're not hearing words, you're hearing meaning. You're not even hearing anything, you're just engaged in that. And that all happens somehow miraculously through these neurons. We don't really know how. We're beginning to untangle a little bit how the neural networks work together as a computer. But if you ask me, how does cells, how do electrons translate into thought? Nobody really knows. There's some theories out there that are very, very thin in details, and really it might not be something that we can know. But that aside, you got neurons, and they do a lot of work. They use a high amount of energy. And how do they get that energy? They get that energy through your plumbing system. And your plumbing system is pipes from the heart that bring the blood to the brain. Those are called arteries, those pipes. And those arteries are thick-walled, muscular, and with every beat of the heart, it squeezes blood, which goes up through the blood vessels in your neck. There's 2 in the front, 2 in the back, and they then branch out into smaller arteries or arterioles, and into, like a tree trunk, into smaller and smaller twigs, and then eventually it reaches the cell, and you bring blood to the cells. What's in the blood that's important? Well, everything that's in the blood is important, but what helps nourish these cells, what helps feed them, give them the energy, is 2 very important things. First, the stuff that we eat that's broken down into glucose and other things that we'll talk about. And then also oxygen. Without glucose and oxygen, your brain, or without the nourishing molecules and oxygen, because there are other things other than glucose that your brain can use for energy. It was thought that it could only use glucose. Turns out it can actually use other molecules as well. But glucose / other things and oxygen is what feeds the brain. Now, it's no good getting the plumbing in, the blood in. You also have to get the blood out. Those are taken out through a system of veins called venous sinuses, and that's what takes the blood away from the brain, brings it back to the heart, where it is nourished with oxygen again. Your liver brings in all the nourishment that it needs back into the blood, and that is how your blood is nourished. Your brain is nourished. Okay, so what is the brain made out of? It's composed of the hemispheres, the big forebrain, and then the primitive brainstem, and then that goes into the spinal cord. What is a stroke? So a stroke is any way that you interrupt that normal flow of blood to the brain. And there are 2 primary divisions of strokes. One is what we call a ischemic stroke, meaning that you get lack of oxygen because of a blockage of the blood. And the other one is a hemorrhagic stroke, or a bleed, where you have bleeding. The blood vessel ruptures and then you bleed, and because the blood, instead of going to a particular cell, is now bleeding all over the place, you are not going to get nourishment. And the bleed itself can balloon up into a big ball and mass and put pressure on the brain. We can divide these 2 further. So in the bleeding type, we have what we call intracerebral hemorrhage or intraparenchymal hemorrhages. And those are when you have bleeding into the tissue itself. And then the other kind of bleed that you can have is what we call a subarachnoid hemorrhage. And that is when you have an aneurysm, or trauma can do it as well, but when the blood vessel ruptures and you get blood forming on the surface or into the tissue. And there are different types of animals as far as what you have to do to treat and respond to them. And unfortunately, we don't have very good treatments for the severe types. Sometimes you can take the blood out, but surgery doesn't always help, and frequently it doesn't help. But there's no medical treatment that we can do other than try and stabilize the patient for those type of bleeding strokes. Fortunately, because they are so frequently severe, they're not the majority type of strokes. The ischemic strokes are the majority. A minority of the ischemic strokes are because of blockages in the veins, in the venous system, in the sinuses. We call where the veins come together, the sinuses. If you get a blood clot forming over there, you can get blood in, but you can't get blood out, and it backs up. And these type of strokes, called venous sinus thromboses, we find them in younger people more than the other type of strokes. It's often associated with smoking and with problems in blood clotting, sometimes inherited blood clotting abnormalities. By far the most common type of stroke is the arterial ischemic stroke, and that's what we're going to spend the rest of our time talking about. This is the common stroke that you think about in the elderly person, where you have a blood clot forming, preventing blood flow getting to the brain, and because of that, that brain is starved of oxygen and glucose and starts to die. And this is the stroke that is responsible for the vast majority of disability in the United States and for 1/5 of deaths, and that's what we're going to talk about today. So, before I continue, you'll notice that there's no PowerPoint here, and that's done on purpose, and it's done so this can be less formal, so we can go off on tangents if you want to. We're not stuck to a PowerPoint, and that also means if you have a question or you want to interrupt, feel free to do so. Okay, I think if you don't feel like you have to look at a PowerPoint, you might be able to have a little bit more fun. It's not easy to have fun with a talk about stroke, but we'll do our best. All right, so we talked about how a stroke occurs. What do you do if someone is having a stroke? And the first question before we can answer that question is, how do you recognize when someone's having a stroke? And so it turns out that in most cases, it's not that difficult. And there are a couple of things that if you notice this, then the first thing that you need to think about is stroke. The most important part is that there is a sudden change. We use the term acute. Strokes occur suddenly. There's a blood clot that suddenly blocks blood flow, and one moment you are absolutely normal, or the person is absolutely normal, and it's like a switch is flipped on or off. Suddenly you cannot do something. So the timing of it, if it happens suddenly. If this is a gradual thing, it doesn't mean it can't be a stroke. We certainly see strokes that occur that begin mild and then get worse with time. But most of the time it's sudden. One of the other things that we know about strokes is that the majority of them are going to affect one side of the body or the other. And so somebody who's generally just becomes weak all over, chances are it's not a stroke. There are lots of other things that can do that. Strokes can do that. Certainly, you can become weak all over, you can become unconscious, you could do all kinds of weird things if you're having a stroke, but the vast majority of them is going to affect one side of the body or the other. And the reason is because your brain is divided into two hemispheres, the left hemisphere and the right hemisphere. And the right hemisphere, on this side, affects everything that the left side of your body and your world does. What do I mean by your world? Well, let's first talk about the left side of the body. My right hemisphere is going to allow me to control my left arm and my left leg. But it is also going to control my ability to move my eyes to the left. It is also going to be responsible for perceiving my entire left universe. So if I have a problem with my right hemisphere, suddenly my left universe doesn't exist to me anymore. And it's a kind of a weird thing to imagine. You would think, oh, you just can't see it, but it exists. Well, it turns out that people who have a stroke on their right side, not only can they not see on the left side, but they actually aren't even aware that the left side exists. And it can be actually quite peculiar, because if your left side doesn't exist, then you don't realize you're having a problem. And that is really true with these patients who have big strokes on the right side of their brain. They don't realize they have a problem, and that's a problem. Because if you don't realize you have a problem, you try and get up and you can't move your left side, then you're going to very quickly run into trouble. You take a patient who's had a big stroke on the right side, and you ask them to move their left arm, and they can't, and you lift it up for them, and it's flopping in front of them like that, and you say to them, whose hand is that? And they'll say, oh, that's your hand. They don't even realize it's their own hand. It's somehow the way the brain processes a sense of self and a sense of body. Okay. The left side of the brain, the exact opposite. If the left side of the brain controls the right side, it's peculiar in that if you have a stroke on the left side and your right side goes down, you don't have that same loss of sense of self of your right side. So if you show them your hand, they'll say, oh, that's my hand, it's just not moving, and I realize I cannot move it. But they will not be able to see on the peripheral vision, on the right visual field, they won't be able to move their eyes over In fact, if you see somebody who suddenly becomes paralyzed and their one side, let's say the right side, goes down and their eyes are fixed to the other side, they're looking in the other side, well, that means that the left side is the one that's had the stroke, because the left side of the brain tries to move the eyes to the right side doesn't work anymore, and neither does the ability to move over to the right. So the eyes stay fixed to the left. Okay, so what the left side does, though, that's really important, is speech for most people. The majority of people, speech is localized to the left side of the brain. That's where first of all, we understand what people are saying, we process what people are saying, and that's also how we are able to speak. If your left side is affected, you may not be able to understand anything, and you may not be able to say anything. If it's a smaller stroke, then you may be able to understand what people are saying, but you can't get the words out. You can't say what you want to say, and guess what? You can't write it either, because your ability to express yourself, whether it's through speech or through the written word, is affected. You can also have no problem speaking, but you can't understand a word. If you cannot understand a word, that means your brain is not processing words. So the stuff that comes out of your mouth is nonsense. It's garbled, it's words that don't make any sense. They couldn't be words, but they're strung together in sentences. And interestingly, people who have this ability to speak but not be able to process information, they don't even realize that what they're saying is nonsense. They'll just talk, and they will not realize that they are having a problem. That's different when they cannot express themselves. When they cannot express themselves, they realize they're trying real hard. They know they're trying to say something. They cannot find the words, and it's very frustrating experiences for them. So you see someone who's had sudden problems with their speech, sudden problems with weakness or numbness on one side, sudden problems not being able to see, sudden problems with moving their eyes, sudden problem with double vision. Your brainstem is responsible for making your eyes move together, all right, or going like that. But if the brainstem is affected, the brainstem, which coordinates the movements, is suddenly not working, and now only one eye moves. So when you're trying to look to the right or left, you're going to see double vision. It's very disconcerting and disorienting for people, and they keep their eyes closed because they don't like to see that double vision. It makes them feel nauseous. So sudden double vision, sudden loss of balance, right? Your cerebellum, you probably heard of that. That's the part next to your brainstem at the back, very old, primitive part of the brain, the part of the brain that allows you to learn how to play the piano, ride a bike, etc. Well, that's responsible for balance. And you have a sudden stroke to your brainstem or the cerebellum, suddenly you can't walk. Suddenly. Because we've all had those experiences where we get vertigo, either we have inner ear problems or we've had one too many glasses of wine, but that is not something that happens like that. It's kind of gradual. If it happens like that, then you've got to be worried about a stroke. All right. How do you remember all these different things? All right, well, it's easy to remember acute onset or sudden onset and then one side or the other, although if you're suddenly paralyzed on both sides, that could be a brainstem stroke. But we've developed a term called B-FAST, B-E, and then FAST, or as they say in this country, fast, B-FAST. This is a way to remember the symptoms that are associated with a stroke. Why do we use the words be fast? And the reason is because you need to be fast in responding to this, and we'll talk about why in just a moment. B stands for balance. E stands for eyes, any problem with your vision. F stands for face, facial droop, or any kind of asymmetry to the face or numbness in the face. A stands for arms, if your one side or the other is weak, okay? S stands for speech, if there's any problems with your speech, and then T stands for time. Now you may be asking yourself, one second, we missed out the legs. Is it not possible to have a stroke just affecting the legs? And that, I would say to you, that's a great question, and the answer is yes, you can have a stroke just affecting the legs, but they couldn't figure out how to put that in, the L in the B fast. So just take it for that, an extremity that suddenly becomes weak. All right. Now, I can tell you that one of the most important things, other than how to prevent a stroke, that you're going to learn tonight is what to do if you're recognizing that someone is having a stroke or if you yourself are having a stroke. And more importantly, what not to do. So, here are the list of things of what not to do. Don't take a nap and see if it gets better. Don't call your relative to let them know you're having a problem. Don't call your doctor to let them know you're having a problem. And don't take an aspirin. And I'm starting off with the don'ts first because I want to emphasize that the most important thing you should do is call 911 immediately. Okay? And the reason is because your chance or your loved one's chance of getting better is directly related to the clock. There are therapies that we can give you that can reverse a stroke. How do they reverse a stroke? Well, they get rid of the blood clot. We get rid of the blood clot, we get blood flow back to the brain. Turns out the brain is the most sensitive to oxygen starvation of all the organs. And so you do not have a lot of time. In fact, the brain cells will start dying within 5 minutes of not receiving any oxygen. But fortunately for everybody here and the rest of the universe, the brain has lots of different ways for it to get blood flow. So if the main way is taken out, you can still sustain the brain through the other ways, through the other blood vessels that feed it, but not for long. And so the key here is to get that major highway that's being blocked, unblocked, so your brain can then get nourished again. Okay, so you call 911 because you want to get to a hospital as quickly as possible, and not just any hospital, a hospital that knows how to treat strokes, and we'll talk about that in a moment. So you call 911 and you tell them, I think I'm having a stroke, these are my symptoms, or I think someone is having a stroke, this is their symptoms, this is where they're located, and EMS will arrive at your doorstep. Should you drive? Let's say it's someone else who's, you're seeing someone there, and you figure, hey, it's going to take 911 15 minutes to get here, and I can be at the hospital in 15 or 20 minutes. That's a real tough one. In general, we say no, call 911. And the reason is because you don't know exactly what's going on. 911, the EMS are the experts. They know where to take you. They can get through traffic jams with their sirens. And so the best thing to do is call 911 because they can do things that you cannot do. What happens if you're driving your loved one in the car and suddenly they stop breathing? Now you're in real trouble. So our recommendation is always to call 911 and get them there as quickly as possible. All right. Any questions about that? Yes?
Does Virginia Beach have any of those mobile stroke units that treat people, to eliminate that time factor?
No, they do not. There are only a few places, a couple of places in the country that do have them. We actually looked at them at Sentara, and what we realized was that you weren't going to save that much time. The benefit of these ambulances is that they have a CT scanner in the ambulance. It cost, I think they were well over $1 million for each one. And when we looked at it, those are good for places where you don't have, which are low density, you don't have a lot of hospitals, and it would take a long time to get the patient back and forth, and you would be able to give the medicines that we treat in the ambulance. But here, there's a hospital within 15 minutes, for most places 20 minutes, so it's not worth it's just wouldn't save you much, and it's a high investment.
Not a trade-off of life versus value?
Well, it's a matter of trade-off of where you spend the money. And so hospitals are investing a lot of money in trying to get these therapies, high-end therapies, in the hospitals and bringing the patient to the hospital instead of bringing just the CT scan basically to the patient. But we did look at it. I personally looked at it to see if it made sense for us to do it here, and we decided that it did not make sense. You would not be saving that many lives. And let me also explain. Let's say we decided to do it, we would get one ambulance, right? Where would we put that ambulance? Right? Most of the patients are still going to come to the hospital. That one ambulance is not really going to be very effective. A lot of that is done for PR, by the way. All right. So What are the therapies that we do? Okay, so there's two types of therapy. There's a medical therapy where we give a medicine that can dissolve the blood clot. This medicine is called TPA, it's well known as TPA. The other name is Alteplase. And it is a medicine that you inject into the veins, and the vein and the medicine kind of distributes through the whole body and finds the blood clot and then degrades the blood clot. So it basically dissolves it. And it is a miraculous medicine. It works very, very well. It only works, though, that we are aware of right now within 4.5 hours. The studies that looked at this showed that beyond 4.5 hours, there was no effect. There's a downside to this medicine, and that is because it dissolves blood clots, it can also cause bleeding, especially bleeding in the brain. And so one of the things that we have to be very careful about is that when we get a patient who's had a stroke, that we know that their problems have resulted from a blood clot and not from a bleed, because sometimes the two look exactly the same. The reasons why you have the symptoms from a stroke is because that part of the brain that does whatever it's supposed to do is now not working. And it could not work because it's not getting oxygen and glucose, or it could not work because blood has leaked out and is now spreading everywhere and interrupting and destroying the neurons around it. If you gave TPA to a patient who's had a bleed, that means that the brain would not be able to try and stop the bleeding, and it would be devastating. So, as a result, any patient who's got a stroke, or we suspect them having a stroke, before we can give them this medicine, we have to do a CT scan of the brain to make sure they're not bleeding. That's why this gentleman was referring to the ambulance with the CT scanners in it, because you can get that CT scan quickly in the field. You don't have to wait until they come to the hospital. Let's say the CT scan shows no bleed, then you can go ahead and give them this medicine. But there is a time limit, and that time limit is 4.5 hours after the symptoms first started. Problem is, we often do not know when the symptoms first started because, as we mentioned, sometimes you don't have the ability to speak. And if you are at home alone and suddenly you have a stroke and you can't speak, then we have to assume that the stroke started the last time the person was seen normal, just shortly after that. Let me give you an example. You're with your parent, your mother, you have lunch with them at the restaurant where you've met for lunch. That's at noon, you leave at 1, and then you expect your mother to call you when she gets home. You don't hear from her, you call her, she's not answering the phone, you get worried. And so you go over to the house, it's now 2 o'clock, and you find your mother there and she's not speaking and she's weak on the right side. We have to assume that the stroke started at 1 o'clock. All right, time lost, no normal, which is when you left. So we can't say that the stroke started when you found them. We don't even assume, we may give them, benefit of the doubt that, they drove home and they were okay. But our time clock starts ticking at the moment that they were last known normal. If you know exactly when your symptoms were or when the symptoms started, then we can put the time there. 4.5 hours is not a long time. And 4.5 hours is not the time until you get to the hospital. 4.5 hours is the time until you push the drug in. And so that is why time is absolutely of the essence. Do not wait a moment. It is possible in the next year or two that we might be able to extend that time period for giving this medicine. There are some studies that have come out recently that show that we can utilize CT scans, a special type of CT scans or an MRI, to find out, even beyond 4.5 hours, there's a subset of people that their brain is still perfusing fairly well, still getting the oxygen, and so they may actually benefit from this medicine beyond. But for right now, it's a hard cutoff, 4.5 hours. There is another way we can help you if or your loved one if they're having a stroke, and that is instead of giving you the medicine which goes into the veins and dissolves everything, we'll target the problem. And what we'll do is we'll do a CT scan with dye in the IV that goes to the brain and fills all the blood vessels. And if we see a blood clot, which means basically the dye is not getting past that blood clot, then we know there's something there, right there, we can see it on the CT scan, that's obstructing flow. Then we can put a catheter in through a blood vessel that we access through the groin, snake it all the way up, grab a hold of the blood clot, pull it out, and guess what? You got blood flow back to the brain. Now, initially we found that this worked only 6 hours after the symptom onset. Then we found, oh, we can actually do it up to 16 hours, and now we're up to 24 hours. So right now, within 24 hours of your symptom onset or time loss, no normal, we can do what is called a thrombectomy and pull out a blood clot. And it actually works really well in select people. Who are those select people? Those are people who are still able to get blood flow to the brain through other methods. If you're completely dependent on that one blood vessel, then you're not going to do well no matter what we do to you, because your brain needs, the neurons need that oxygen and glucose. And so therefore, if they don't have it, it just takes a few minutes. All right, but what it means is that there are some neurons in there, some part of your brain that is in shock. It's not working, that's why you can't move one side of your body, but if you save it in time, then those shocked neurons can repair themselves and get back into action. And where I've seen people who are completely paralyzed on one side, not talking, and within hours are completely normal. And it's really wonderful to see. I've seen it actually happen within minutes of giving this TPA medicine. All right, so that is why you don't call your doctor, you don't call your loved one, you don't take a nap, because time is of the essence. You want to get to the hospital as quickly as possible. I also said don't take an aspirin. The reason why you shouldn't take an aspirin is not going to help you, but if you've had a stroke or your loved one's had a stroke, you might choke on the aspirin because your swallowing ability may not work very well. So although you're told and everyone knows if you're having a heart attack, chewing on an aspirin and it works for that, it doesn't work for stroke, so don't do that. All right, now the key here is that you have to get to a hospital that can treat a stroke with TPA or with this procedure we call a thrombectomy. How do we do that? Well, it's a lot of work, as you can imagine, to have these teams ready at a moment, because it can happen at 2 o'clock in the morning, and you need to have people ready to go. We expect in our Sentara hospitals that from the moment you hit the door of Sentara till the moment that drug is being pushed, it's less than 45 minutes. We want to, from the moment you hit that door to the moment you're getting the procedure, to be an hour or less, or 80 minutes or less. And so it's a lot of work. And not every hospital has the resources to do that work. So the EMS know that, and this is actually a Virginia state rule, is that if EMS comes and finds someone who's having a stroke, to bypass a hospital that is not set up to handle strokes, so there's not a stroke center. And that was primarily developed for TPA. Now that we've got all this information about thrombectomy or using the catheter, now the question is, do you bypass a hospital that can give you the medicine but cannot do the procedure? Because these procedures are very sophisticated. They require a cath lab, they require a whole team, and they require doctors that can go in and do this. Those doctors are few and far between, and most hospitals do not have them. And for instance, in Sentara, or I should say in Virginia Beach, right now the only hospital in this area that can do this on site is Norfolk General Hospital. Princess Anne, Virginia Beach, Bon Secours, the other ones around here, they don't do that. So if they get a stroke patient who needs one of these procedures, then they send them to Norfolk. So the question, the big question now is, should the EMS folks, if they get a patient who's having a stroke, just bypass all the other hospitals and go straight to the one that can do the procedure? And the answer to that is, we don't know. And here's the question. If we know for sure that the person is not going to benefit from the TPA, let's say they're not a candidate, it's outside the 4.5-hour window, or that the TPA won't help them, or whatever reason that they're not going to get TPA. Maybe they're on a medicine that prevents you from getting the TPA, the alteplase. You cannot be on a blood thinner like Coumadin if you're going to get this medicine. Then, of course, if you can't, what's the point of taking you to a hospital where you can only get the alteplase? If that's not going to help you, then you need to go to a hospital where they can do the thrombectomy, the procedure. But then again, you also have to know that they are going to find that blood clot. And really, it's only the people who have the big strokes that you can actually see the blood clot. The other thing is, we don't know exactly how good the hospitals are. So let's say we know that Hospital A can give the TPA and Hospital B can do both the TPA and the procedure. But you'll get to Hospital A quicker and you can get the TPA going quicker. I would think you should probably do that. That's my bias. If you're a doctor who pulls out the blood clots, guess what they're all saying? They're all saying go to the hospital where you can pull out the blood clot. I'm a bit on the fence. I don't really know that. But I know for sure that making it a blanket rule that you go where they say you should only go to a hospital where they do the procedure doesn't make sense. And here is why. It all depends on the actual hospital. If Hospital A can give the alteplase really quickly, and we'll get that alteplase going really, really quickly, and they're also really good at transferring quickly, so if you do need the procedure, they can get you over there quickly, then you can make a case that Hospital A, you shouldn't bypass Hospital A, go straight there. However, let's say that Hospital A is terrible. They can give you the medicine, but it's going to take them 90 minutes for them to get you the medicine. So what's the point in going to that hospital if it's closer, if it's going to take longer anyway? And so really, what I would say is, the answer to the question is, if you had the ability to say bypass or not bypass, I don't know the answer to that question, but what I would suggest is that if you have a loved one with you who is at risk for a stroke, you get to know the hospitals that are around you and how good they are, what they do. And this is public information. They're supposed to publicize how good they are with their stroke processing, and that they can do it in a rapid time. That is the key. And I can tell you, as the medical director for the stroke system for Sentara, all our hospitals are really good. They're all getting regularly door-to needles under 45 minutes. So that is very important for you guys to know. Okay, any questions about that? Yes?
I have a quick question. So who determines about the bypass in the hospital? I know it's not I mean, it is EMS technically, but it's like the higher up, it's like EMS 5. They determine if they bypass a certain hospital and take them somewhere else, or, so who would, are they ultimately the ones that make that decision?
Yes, they are.
What, the paramedics or?
Each EMS has a plan, and they make that determination. On the peninsula, they've determined that they're going to bypass over there if it's within a 10 or 15 minute, if it's less than 10 or 15 minutes difference. On the south side, they've decided not to do it unless it's clear you cannot get TPA. And the only way it's clear you can't get TPA is if clearly the time of onset was beyond 4.5 hours.
Taking that into consideration, how do you factor in ER wait times?
So if you're going to the right place, there is no ER wait time. So the procedure is when there is EMS has a patient who's a stroke, they call ahead to the hospital. Another reason why you should go with EMS. The hospital calls out an alert. We get a page. The whole team is ready. That person comes. Doesn't even get checked into a room. They go straight to the CT scanner. So the ED doc takes a quick look at them, and then they have, we use what we call a telestroke service, which is basically it takes a while to get a neurologist to stop what they're doing, get out of bed at 2 o'clock in the morning, and drive into the hospital. So we now have someone on call 24/7 who immediately is available to get on through a video camera into every emergency room in the Sentara system, at least, to assess the patient right away. So they bypass all the way. All right, so we've spoken about what to do if you or you're watching someone having a stroke. Don't waste any time, recognize it's a stroke, call 911, get in there quickly. What happens after you've had the stroke? Either you're getting better, or maybe you haven't gotten better, maybe you've got treatment, maybe you haven't gotten treatment. So there's two main things. You're going to be admitted to the hospital, And two things are going to happen. First of all, you're going to be stabilized. We want to prevent complications after a stroke. And the most common complications after a stroke are basically you can get a blood clot in your leg or your lungs. We don't want that to happen, and that's because now you're not moving very well. And the other thing that is very common that you can get is inflammation of the lungs because you're not controlling your secretions very well, your mouth is not functioning very well, and so instead of secretions going down into your belly where they normally go, they go into your lungs. If you're like me, every once in a while I'll drool in my sleep and I'll go down the wrong way, I'll wake up coughing. If you've had a stroke, you may not have that strong cough reflex, and that can cause inflammation in the lungs. Those are the two things that happen most commonly that we try and prevent happening, and we do that by very carefully checking the swallowing function for everyone who's had a stroke to make sure that they can swallow, and if they can't, we get a speech therapist on board to help us get the right consistency of food so they can eat safely. And then we also, people who are at risk for having a blood clot form in the legs, we give them medicines to prevent that from happening. So that's number one. We want to prevent a complication from happening. Number two, we want to assess why you had that stroke, because there are different reasons why you can have a stroke, and we're going to talk about those. But the most important thing is to try and prevent another one from happening. There is a third thing that happens there as well. I should have said three things. The third thing is you get rehab. Very important part of your post-stroke care is getting rehab to get whatever part that is not working again. And I feel strongly that rehab is probably one of the most important things, aspects of your post-stroke care, because good rehab will make the difference between how quickly you can get up and about. All right, so let's talk about finding out why the stroke occurred. So we said that a stroke occurs because the most common form of stroke occurs because you have a blockage of blood in the arteries. Now that can happen for a variety of different reasons. One common reason is because your heart goes from a normal rhythm into what we call atrial fibrillation. It's an abnormal rhythm. And when it's an abnormal rhythm, the heart is not pumping smoothly, and you get little blood clots forming in the heart, which then pop off and go to the brain. That's a minority of patients, but it happens fairly frequently. I'm going to focus on the most common reason because we only have a limited amount of time, and this is how it relates to preventing a stroke. The most common reason why people have strokes is because of atherosclerotic disease. What is atherosclerotic disease? It is a disease of the blood vessels. It is the same disease that causes heart attacks. So strokes are not a disease of the brain. It's the disease of the blood vessels that feed the brain. Heart attacks are not diseases of the heart. They're diseases of the coronary arteries that feed the heart. And what is this atherosclerotic disease? You've probably heard about it all over the place. Atherosclerotic disease is simply hardening of the blood vessels. And when the blood vessels harden, they become calcified. You get little calcium crystals forming in them. You get fat entering the fractures in the wall, and you get these plaques that build up. Now, if they build up in one of the big, large blood vessels that come and feed the brain, it's called large vessel atherosclerotic disease. But they can also affect the tiny, small little branches within the brain, and that would be called small vessel atherosclerotic disease. But it's really the same process. And this is why we have strokes. You have atherosclerotic disease. And so what we do when you come into the hospital is we do tests to make sure to see that you've had the stroke, and we look for the atherosclerotic disease, and then we decide how do we do what is called secondary prevention, prevent these diseased blood vessels from causing another stroke. And we're looking for what are called risk factors for atherosclerotic disease. And those risk factors are high blood pressure, one of the most common ones. If you have high blood pressure, that's going to make more trauma to the wall of the blood vessel, make it more susceptible to atherosclerotic disease. High cholesterol. We know that if you have atherosclerotic disease and you have high cholesterol, and we refer mostly to, when we say high cholesterol, to the LDL component of high cholesterol, low density lipoproteins. By the way, there is no evidence that high cholesterol there's two types of high cholesterol. There's dyslipidemia, or abnormal high cholesterol, where your cholesterol levels are off kilter. Your LDL is high, your HDL, which is the good cholesterol, is low, and your triglycerides are high. But there are people who have high LDLs, but also high total cholesterols, but also high HDLs, and maybe the triglycerides are low. There is no evidence whatsoever that people who have that type of a high cholesterol are at risk for heart disease or strokes. That might be a little bit of the controversial part, because the doctors don't want to publicize it too much, because they're worried that people are not going to treat the high cholesterol if they start saying, oh, well, I have this type or that type. And there is a very good treatment for this kind of high cholesterol, for the abnormal kind of high cholesterol, and that is statins, Lipitor, the #1 best-selling drug in the universe. Okay, or I should say, I don't know if it's the best-selling drug, but it's the most profitable drug. And so if you have high blood pressure, you control your high blood pressure with medicines. If you've got high cholesterol, you control your cholesterol medicines. Medicare has insisted that we do this, and a lot of effort is put into making sure that these things are treated so you don't have another stroke. Another one, diabetes, very strong risk factor for having a stroke, for having a heart attack. Interestingly though, and we'll come back to why this is interesting in a moment, if you have diabetes and you've had a stroke, and then you control your glucose very well using insulin or being careful what you eat, that doesn't reduce your risk of a subsequent stroke. So we'll keep that in the back of my mind. Why is that the case? If diabetes is a risk factor for a stroke, why doesn't controlling the glucose help? Then of course there are things that you can do something about, like smoking. What do we do about smoking if you do that? You stop. All right. Another question I get frequently is drinking. Is drinking a risk factor for a stroke? Drinking excessively is a risk factor for bleeding. Drinking 1 or 2 drinks actually reduces your risk for an ischemic stroke. So having 1 or 2 drinks a night is not a risk factor. More than that is. All right then. Drugs. Do drugs increase your risk for stroke? We know that amphetamines, cocaine, and those type of drugs are very strong associations with strokes because it causes an inflammation of the blood vessels. All right, and then so those are the risk factors we have for targeting patients who've had a stroke, because then we can say, oh, you've got a high blood pressure. Okay, we're going to treat your high blood pressure. You've got diabetes. We're going to make sure you're on a good regimen of insulin. You've got high cholesterol. We're going to treat your high cholesterol. Okay. Are there any other risk factors? Well, of course, diet and exercise. Okay. We talked about all these risk factors, but there's one risk factor that we didn't talk about, and that is age. All right? We're noticing more and more people are getting strokes when they're younger, but in general, we think of strokes as something that happens to the elderly. And the reason why I left this risk factor to the last is because it's really bogus. Age is not a risk factor, and I don't like the fact that people say that age is a risk factor, because what it gives people is the impression that there's nothing you can do about it. Unless, if you want to stay alive, that is. Right? If you want to go on living, you're going to get older, and somehow you are helpless to the affliction of age, that you are more likely to get a stroke. Well, it turns out that age is associated with a stroke, but it is not a cause for a stroke. What is going on here, and what am I getting at? What I'm getting at is that the true underlying problem of strokes is actually the fact that we are overusing 2 hormone systems that our body has been designed to use, but only in little spurts. One is insulin. Insulin is a drug that is used to control metabolism. And one is cortisol, or epinephrine on that axis, which is used to control stress. Metabolism and stress over long periods of time are going to cause atherosclerotic disease, and they're going to cause heart attacks, strokes, dementia, and a whole host of other things. You can do something about this. Let's talk about this a little bit. I mentioned metabolism. If you noticed, when I said I was going through the risk factors, I threw in a couple things at the very end. What were they? Diet and exercise, all right? Have you been to the doctor's office? How much time do they spend if you're at that point in your life where you got diabetes, hypertension, and they spend their entire office visit talking to you about how important it is to take your meds, and then they throw in, healthy diet's going to help, and exercise. I spent about 15 seconds telling you about diet and exercise, and that is typically what your doctors are going to tell you. But the truth is, diet and exercise, actually more so diet than exercise, and we'll talk about that if we have time, is far more important than all this other stuff. What you eat is far more important than all the other stuff. And the reason is, because if you eat properly, if you eat carefully, if you're aware of how the food affects you, then you're not going to develop hypertension. You're not going to have a problem with cholesterol. And you're not going to have a problem with diabetes. These three diseases, which are sub-diseases because they lead to diabetes, they lead to strokes, they lead to heart attacks, they lead to probably Alzheimer's as well. These are all caused by problems of metabolism and stress. So let's dig into that a little bit. But this is my message to you. If you take one thing away, is that you have the power to prevent all this stuff from happening to you. But you need to be aware of how your body functions. So let's talk about how the body functions. And it's not just the human body. Any organism, in order to survive, needs to be able to do three things. It needs to have metabolism. What does metabolism mean? It means you take in food or you take in energy because you need to grow and you need to move around to survive. So metabolism. You need to have a stress system. That stress system prevents you from getting eaten by something else. All right? So you need to be able to have your fight and flight response. And then the third thing you need to do is reproduce. We're going to leave that reproduction part to another lecture because that's not really relevant to the discussion today, but your fight or flight response actually helps in that part as well. So we're going to talk about metabolism and we're going to talk about stress. Let's look, what do we mean by metabolism? We're talking about intake of energy, all right? And basically food, diet, what you eat. Now, I will tell you that if you go and ask your doctor, what is the right thing to eat, or you ask this professional or that professional, and they'll all give you a different answer. You need high carbs, low carbs, plant-based diet, you need to be vegan, you need to be only eat meat. And then if you go into the library, in the diet section, you see a huge amount of books all about that. And I'm going to tell you a secret. It is very easy. It's very straightforward. If you want to worry about your weight or how much you eat, and this is not a lecture about weight, but we're segueing into a little bit, it's very easy. Calories in, calories out. Now, before you roll your eyes and you say to me, all right, I've heard that one before, but it's ridiculous. Obviously, it's not calories in, calories out, because if it was calories in and calories out, nobody would be overweight or heavy or having a problem because they would just know, stop eating the calories. So obviously, it has to be more than that. And obviously, the books on the shelves in the library are all have realized that calories in, calories out is not true. And so what I will tell you is that unfortunately, the laws of physics cannot be overruled. And the laws of physics is the energy conservation. You cannot, if you do not have calories in, you can't get fat. And if the calories go out, it's just an equation that you cannot mess with. And the reason why people have a problem with the calories in, calories out is because, number one, they are right. It's not that simple. And number two, they're missing the point. Because most people think that the calories in part, how you decide what you eat, is up to you. But it's not. Turns out that the calories in, what you eat, has about as much to do with you as right now what you're determining about your heart rate. Are you thinking about your heart rate? Are you saying what your heart rate should be? No, it happens automatically. The amount of calories that you take in are not controlled by you. They're controlled by a whole bunch of additional processes. Yes, you pick up the food and you put it in your mouth, but how many times have you been picking up food, putting it in your mouth, and not even realizing you're doing it? All right? Calories out. What do we mean by calories out? Well, energy usage. So, how do we use energy? Well, there's two main ways that we use energy. One is activity, movement, exercise, running, thinking, right? Thinking takes up a lot of energy, 20% of our energy. And there's also heat generation. We generate heat. We generate heat because we need to keep our body in a very close range of temperature. Babies, when they are born, have very little muscle, right? And because they have very little muscle, they don't generate a lot of their own heat. And so they have a mechanism whereby the food calories that they take in, instead of being used for energy and muscles, are actually broken down and give off heat. They're like little heaters. And they do that, and the generator of that heat is through their fat. A particular type of fat is called brown fat. Have you ever had that friend that could eat whatever, they shovel it all in, they can eat whatever they want, and they're skinny, right? These people are genetically gifted in that they burn a lot of the energy that they take in as heat. But it's also genetically, how you are made will determine on how active you are. And so the amount of energy that you put out is also determined genetically, and the amount of food you put in is actually is partially genetically determined, but in fact is mostly a result of the Western civilization environment that we live in, and we're going to talk about that. And the reason why I'm talking about diet at all here and weight is because it relates to the problem we have with insulin. So the human body has been very, very carefully evolved to to benefit from the nutrients around it. Just like every other organism, the GI system, the entire development of an organism is adapted to their environment, so they have the most efficient way of extracting nutrients from their environment so that they can propagate their species. In the human being, the vast majority of the development of the human being has been through the Paleolithic era, where they were hunters and gatherers. And now you're going to say, wow, this guy's had a real sneaky backdoor area to promote paleo diets. And what I'm telling you is I'm not promoting the paleo diet, because the paleo diet is not, I'm not taking away from it. I'm not saying the paleo diet is wrong, but what I'm saying is the way the food that was available to us in the Paleolithic era was absolutely completely different to the paleo diet that we have now. The fruits that we eat, the vegetables that we eat, they look nothing like what was in the Paleolithic era. But however, the concept is important, that we did not have easy access to sugar. And that's actually going to be the key of what I'm telling you. The pancreas is an organ, a little organ in the GI tract, and it secretes this hormone called insulin. And this hormone, its job is to take the sugar that is in your bloodstream and get it out of the bloodstream really, really quickly. Why does that have to happen? Why do you have to get the glucose out of your bloodstream really, really quickly? And that is because glucose, although it is really useful for energy, can also do damage to everything, including the the red blood cells and a whole host of other cells that it gets exposed to. So we want to minimize, we want to very tightly control how much glucose there is in your bloodstream. So the pancreas was made to do just that. Also fat. Insulin helps take the fat and the glucose out of your bloodstream and put it in the cells where they are stored for their energy. So, our bodies evolved in a time where there was not a lot of sugar around. Even the plants that we ate did not have a lot of sugar. We did find high concentrations of sugar in the form of honey, sometimes in berries, but even the berries were not that high. We developed in our brain a tool to make sure that if we ever did get exposure to high sugar substances, we would take advantage of that. And the reason is because these food substances, these sugars, are very high and concentrated in energy. And you needed to be able to have that energy to survive. And so even though most of the time you weren't exposed to high sugars, when you were, you needed it. And so your brain said, I like sugar, and every time you had that sugar, your brain is going to say, oh, this is good, I need some more of it. So therefore, you're more likely, because you like it a lot, to go and climb that tree and risk getting stung by bees to get the honey and other things. All right, so fast forward about 2 million years, and we've gone through the whole hominid population. We've gone through the, we're now in the modern day Homo sapiens, and 20,000 years ago we started the agricultural revolution, and suddenly we start growing plants. And now we get more exposure to the plant foods, more sugars because carbohydrates in plants get turned into sugars. And then in the 1800s, we start developing the sugarcane and sugar beet industry, and suddenly sugar, sweet stuff, which used to be only available to kings and rich people, are now rampant. And then you have the beginning of the era where people died from hunger. Now they started to die from obesity. Our pancreas, which was designed to see only small amounts of sugar at a time, is overwhelmed by the sugar in all our food right now. You cannot find a processed food without sugar in it. I bought fish sticks yesterday for my kids. Sugar, maltodextrin, dextrose. Why do they need sugar? Why do they need sugar in ketchup? And the reason is because if they don't have it, people wouldn't eat it, because people have been addicted to sugar. The sugar is rampant everywhere, and it is what is generating this epidemic of diabetes, because what happens is this pancreas can't keep up, it's making that insulin. Let me backtrack. There's two types of diabetes. Type 1 diabetes, where the pancreas breaks down, has an autoimmune disease, it's destroyed by your own autoimmune process. That's not what I'm talking about. I'm talking about the type 2 diabetes. Type 2 diabetes occurs because you're making insulin, and you're making so much of it because the sugar is stimulating it constantly that your cells in your body, which have receptors for the insulin, start ignoring it. Oh, I've seen that insulin too much, and they start becoming insulin resistant. It's the insulin resistance that causes a lot of the problems we have today, and we don't have enough time to go into the how exactly that works. But what I would tell you is, don't believe a word that I'm saying. Look it up for yourself. Insulin is an important hormone for our survival, but when it's stimulated too much, the cells in your body become resistant to it. They've seen it, and they change so that now you need more and more insulin to get the same effect. And so now you've got a lot of insulin. And that insulin is taking all this fat, and instead of fat being used for energy, is now being taken up into your cells. What is the function of fat? White fat, not the nice brown fat that we all like to have some more of to burn that extra energy is heat. By the way, in case anyone is thinking of going on Shark Tank with an idea that you're going to develop a drug that increases brown fat, you're too late, it's already been done. Company came up with this drug that basically dissociated, it didn't make you have more brown fat, it dissociated, decoupled the mechanism of using energy to power, and it just basically used it to generate heat instead. So all this extra food that you took in generated heat, and you would lose weight. And they were very successful in making people losing weight, but unfortunately they did not know how to control it well enough, and so people died from hyperthermia. They got too hot and they died. And so when more than a bunch of people died, they had to stop that. So probably not a good idea. All right then. So what does white fat do then? A lot of people think that white fat just is there to make you have problems getting your jeans on, or to feed your desire to get to the gym. But it turns out that the white fat creates inflammatory molecules, and they secrete them. And so the more fat you have, the more likely you are to have inflammation. And I'm using this as a segue to stress. What did we need epinephrine for, adrenaline? What did we need cortisol for, which is part of that hormonal axis that releases stress in the long period that we evolved as human beings? Well, we needed it we were sitting around, enjoying each other's company, relaxing in the woods, taking it easy, and suddenly a lion appears. You need to get your heart rate from 60 to 120 really quickly. You can't be sitting back there and thinking, oh, that's cool, that's a lion, wow. No, you got to get up and run. And the way you do that is you have an adrenaline response. If you had a neighboring band of folks who looked like they were trying to take the berries from your berry patch, you need to get angry. You need to stimulate your autonomic nervous system to get very, very revved up so you could defend yourself. Fortunately, now we're not in a situation too often where we come face to face with a lion, although I heard not too long ago I read this article in the newspaper where I think someone got eaten or attacked by a lion in a safari because they got out and got too close, which I would say is absolutely ridiculous. But just the other day I was in Florida about this far from an alligator and my dad said to me, "You're an idiot." I was like, obviously the alligator is not going to do anything. This is in a park. Everyone's walking by it. And it's docile, so I was fine. And he's like, yeah, you're fine until you're the first person that gets eaten. But anyway, we don't have, most of the time, for most sane people, alligators and lions ready to attack you. And fortunately for most of us, we don't have to protect ourselves from roving bands. We have the cops do that for us, although sometimes you've got to be careful. My point being is that our body was made to release these stress hormones, so it now, if it doesn't have lions to worry about, it tries to attach to something. And so instead of having our stress response to things that we needed it for, now we have it to the iPhone doesn't work, we're stuck in traffic, I need to advance my career. I am arguing with my loved one about something. I don't need to tell you this because you know how often in the day you feel that stress about stuff that is really not life-changing. And the problem is that we don't have obvious control over that. It controls us. And when you go through life chronically like that, that will take its toll. That stress response, that is not just a feeling. Those are chemicals, those are molecules in your blood that are moving around, stimulating cells, causing the fats to, and if you have more fat cells, there are going to be more of these, and it's going to cause atherosclerotic plaques. You have a buildup of atherosclerotic plaque in your blood vessels, but that's not what kills you most of the time or what causes the stroke. What causes the stroke is a rupture, an ulceration in that plaque. And that occurs from a release of stress hormones. It's chronic, just like the chronic secretion or use of insulin. These two things over time are going to end up causing problems with your heart, problems with your brain. And that's why it's not really age. Age happens to be the bystander there. Age, these things won't work overnight. It takes a long time. And that's why with people as they age, they get more and more and more of this stuff occurring. But you do not need to be powerless as to the kind of food that you take in that stimulates insulin, and you do not need to be powerless to the stress. The stress is actually really, really hard. The easy part of stress, and the thing that goes unrecognized, is one of the big problems related to stress is lack of sleep or lack of appropriate sleep. Sleep is really critical in modulating stress. I mentioned earlier that diet and exercise are important, and then I said, well, diet is more important than exercise. People have this idea that exercise is important because it controls your weight. Anyone who's tried to use exercise to control weight knows that's not true. Maybe very briefly. What happens is that as soon as the body loses weight from exercise, it switches it, either downgrades the metabolism or makes you tired after that exercise. It is very difficult to get to a point where you're losing weight from exercise. The closest you can get to that is if you exercise regularly and use weights and you build up muscle mass, your muscle mass is going to increase your is going to raise your resting metabolism. But exercise itself is very important, but not because of controlling your weight. Exercise is really important because of controlling your stress and helping to promote healthy blood vessels by helping your heart deal with the changes in the rhythm. There is only one way to reduce the risk of Alzheimer's, or one factor that we know is associated with a reduction in the risk of Alzheimer's, and that is exercise, physical activity. So physical activity is important, but not as important as diet when it comes to things like weight management. So what does this mean for us? First of all, you need to recognize how dangerous the food that you eat is. The reason why it has not been recognized so far is because it happens really slowly and quietly, and no one's really talking about it. For a long time, the US government stayed completely silent about the FDA, you know, in the food pyramid. They stayed completely silent about sugar. Why was that? Why are we at a stage now where we have so much sugar in our foods? Why did that become a thing? And the reason is because way back in the 50s, the medical community thought, and maybe they were right, maybe they're not, this is a big debate, but they saw these atherosclerotic plaques and they saw lots of fat in them, and they said, fat is bad for you. Why? Because you have a stroke, you have a heart attack, look at the blood vessels, they're full of fat. So therefore, if those are full of fat and causing you your heart attacks, don't eat fat. So you'll all remember when the fat-free fad came out and everything started to be made fat-free. Well, what did that do? If you take fat out of food, what is that going to do to the food? Taste. It tastes awful. So what do they do instead? They put sugar. So they put sugar in, and they said low fat as if it was a good thing, and then they put the sugar in. So now let's back up. What makes you feel full? There's two primary ways that a person feels full after eating. One is you have stretch receptors in your stomach. So when your stomach is literally physically full, those stretch receptors send signals to your brain and tell you, hey, your stomach's full, you better stop eating, otherwise you're going to burst. There's another mechanism, and that is hormones. Certain foods release hormones that stimulate your brain and tell you you're full. Have you ever heard of the term, oh my God, that meal was so heavy? What do we mean by heavy? It means you get full quick. What are heavy foods? Primarily fatty foods and protein. To a lesser extent, protein will also make you feel full quickly. So we took away from our foods the stuff that tells you stop eating, and we put in the stuff that is addictive, as addictive as cocaine in some studies. Sugar, that tells your dopamine pathway in your brain, this is something that you need to do more and more and more of. It's kind of like the people who are addicted to heroin. It's the same process. And so you're taking away the thing that tells you to stop eating, you're putting in this thing that tells you to eat more and more, and that's why we only stop eating when we literally can't move anymore, our stomach is full. And sometimes we get to the point where our stomach is full, we can't eat a thing, and they bring out the dessert menu, and suddenly we can find more room. Why is that? That's because this is the sugar in really concentrated form telling you, yeah, you've got a little bit more that you can do. All right, so I'm not telling people that they should be eating high fat and low carbs. Every person's body is different. It's going to be different in genetics. It's going to be different based on the bacteria that they have in their gut. What we're finding out more and more now is that the bacteria in your gut, which, by the way, there's more DNA from bacteria in your body than your own DNA. They harbor all kinds of waste products that can either help you or harm you, and they do have an impact on illness, on disease, and in weight. They did an experiment on mice, and they had genetically engineered mice to be fat or thin, and they took the feces out of the fat mice, put it in the thin mice, and guess what? The thin mice became fat. And so it seems like there is some association from what the bacteria are doing to how it impacts your brain. This is not ready for prime time. We do not know enough about it to know, oh, does getting an enema work? Does eating probiotics work? We don't know anything yet. But it probably will at some point get to the point where we will understand. But even if we understand that, it's probable that the type of bacteria you have in your gut is directly related to what you eat. It's directly related to what your mother ate. In fact, if you look at subsequent generations of obesity and diabetes, it occurs younger and younger, at younger and younger ages in subsequent generations. And there's a lot of evidence to suggest that it's being passed down maternally from a mother who eats a certain way to the fetus. And so it is a real problem. It's a real problem because we don't have any control over what our kids eat. We think we do. We can control what's in the house, but we certainly can't control what's out of the house. We can't control the teachers that reward the kids with candy. We cannot control all the TV ads that promote candy. We can't control Halloween. We cannot control the fact that everybody else eats this stuff, and that you really are powerless to do, at least to a large extent, to dictate what your kids eat. So it's a real problem, but I think that recognizing that the food you eat is going to have a long-term impact, even though it doesn't necessarily have a short impact, is important. So I've given you a whole bunch of information. How is it actionable? What can you actually do about it to make a difference? This is the reason, by the way, that the doctors who do know this stuff don't talk about it, because it takes a long time, and it's really difficult for an individual to tell them what to do, because for one person a certain type of diet may work, and for the other a different type of diet may work. But my point is what you eat is really going to dictate how much you eat. So the calories in, calories out, while that is true, if you're eating a lot of high sugar products, a lot of high carbohydrate products, a lot of non-complex, simple carbohydrates that are easily broken down to sugars in your gut, you're going to end up eating more and more and more. You're probably also not going to be using as much energy on the tail end either. And so this is what I would say to you if you're saying, okay, well, what do I do with all this information? Number one is get to know how many calories you should be taking in. It's not easy to do that in an accurate way. There's this thing called indirect calorimetry where you can pay places, there are not too many places that do it, where you put on a gas mask and you breathe in and out, and they calculate based on the gas exchange how much energy you need from your resting metabolism, and then they'll give that to you in calories, how many calories you should have, and then you add on more for how active you are. But there are also equations. You can go on the web and look at what is my resting metabolism, and then you put in your age, your sex, your height, your weight, and all that kind of stuff, and they throw out a number. It's not very accurate, but it's the best we have. But you need to have some sense of what you should be eating in terms of calories. And for most people, it ranges from about 1,500 calories to about 3,000 calories for most normal people of normal weight. Obviously, if you're big, you have a lot of muscle, you're going to expend more calories. If you're working all day, doing manual labor, you're going to expend more calories. But you'd be surprised by the difference between what you think you should be taking in and what it is, and also how much you're taking in. Most people are not aware of the calorie value of their food. So, first step is get a sense of what your calorie intake should be. And the second part is pay attention to how the foods make you feel. I would say very easily, rule number one, get rid of any excess sugar that you're taking in. So don't add sugar to anything. Sugar is not a natural substance by itself, unless it's in the form of honey. And honey, you shouldn't be eating honey unless you've climbed that tree and got it yourself. So many foods now say, organic pure honey, as if that's a good thing. It's the same as organic pure corn syrup. It's the same molecule when it hits your stomach. So cut out all excess sugar, don't buy processed foods. So in addition to the processed foods having sugar in it, they also have a complete lack of real nutrients. I'm not talking about the added vitamin C's. By the way, if you're taking over-the-counter, if you buy vitamin C or you buy vitamin A or whatever it is, vitamin D, do a little bit of research on it, because a lot of these vitamins don't really contain most of the stuff that they say that they're containing. They're not very pure. But anyway, these processed foods are really deplete of real nutrients. And that's why you eat so much of it, because your body knows what nutrients it needs and it's not getting it. So it keeps on telling you, eat more, eat more, eat more, because you need those nutrients. That's why diet sodas make you fat. That's one of the weird things. Diet tells you take out all the calories, take out all the sugar, and so how come you're still fat? How come you're still putting on weight? It's because you're drinking and you have that sweetness. That sweetness stimulates a part of your brain that says, I've received energy, but then the energy doesn't show up. So now it's panicking, and it's telling you, eat more because you promised me energy through that sweet taste, and I haven't gotten it yet. So processed foods are bad for you. I don't want to, it sounds like such a cliche, but I'm hoping that if you understand why they're bad for you, when you look at the stuff, it's not really the chemical. People say if you can't read it, it doesn't make any sense, then you shouldn't be eating it. It's not so much of what of the chemicals. It's the sugar and the lack of nutrients that are there. Should you eat high fat or high carb? What I would say is that you don't have too many carbs because carbs turn to sugar eventually. You don't want to have too much fat if you're also having carbs, because then the fat is going to, if you're secreting insulin, that fat is going to find its way, excess calories. And if you're eating a lot of carbs, you're not going to be necessarily satisfied and you're going to eat more than you should. So there are diets out there. There's the ketogenic diet, there's the paleo diet, there's the plant-based diet. Each one of these are good as long as they get rid of the sugar, they get rid of the processed foods, and they suit you personally. And so what I would tell you is pay attention to the amount of calories that you're taking in. If you're struggling and you're hungry, it means you've got a problem. Do not go on a diet that makes you hungry. Go on a diet that makes you full. It just needs to be the right amount of calories. And if you're eating too much, then change the food so that you don't feel hungry. We seem to be slipping back, or I seem to be slipping back, or talking about diet and weight gain and weight loss. And the reason is because this is directly related to the kind of problems of metabolism that lead to diabetes, hypertension, and dyslipidemia, or abnormal cholesterol. And so they're all interconnected. We, starting at a younger age, can prevent, when we get to the older age, having to deal with high blood pressure, having to deal with taking a statin like Lipitor, having to deal with insulin or insulin or sugar-lowering medications, if we're very careful about how we eat and we're also careful about stress. So I have 10 minutes left. We were supposed to have half an hour for questions, so I will stay back for any questions that you have afterwards. But I want to take 3 more minutes to talk about stress. It is probably the most rampant disease that we have in the United States and elsewhere. And it's a real difficult problem to overcome because we seemingly have so little control over it. We don't realize we're getting stressed until after the fact, and frequently we don't even realize it then. It's become a normal part of our life. And so what do you do about stress? How are you able to overcome it? So a lot of people will tell you, well, avoid stressful situations. Thank you, right? It's no matter, separate yourself from a relationship that is unhealthy. Look for friends that have a positive influence. But we all know, although those things are important, there's always going to be stressful situations, and they're constant. And so what you have to do, if you are willing to put the effort into leading a healthier life and into actually a happier life as well, is you have to figure out a way where you don't respond, you don't react in the primitive way that our bodies are built to react. Now, fortunately for us, we've got this thing in our brain all the way at the front called the frontal lobe. The frontal lobe is a part of the brain that is fairly unique in humans in that it is the most evolved. It allows us to think beyond the present. It allows us to think abstractly. It allows us to analyze and assess problems. And what it allows us to do is also to mitigate some of these stressful situations where normally we would just be responding, reflexively. And there has been this big movement over the past 10 or 15 years, mindfulness, which is code word for meditation. All right, people don't like to use the word meditation because for some people it's a little hokey, you know, to associate it with religions or cults. But the bottom line is what these things do is allows you to slow down your brain and then to become aware of how you respond to your environment. And then you start paying attention to the things that set you off. You start to learn about how to calm yourself down. And if you do it long enough over time, you're actually able to change your brain so that you don't respond reflexively to certain situations that will make you stressed out. It takes a long time. And the reason it takes a long time is you actually have to change the architecture of the connections of your brain, because the reason why you act a certain... If you looked at me a certain way, sir, I would not take offense to it. But if my wife looked at me the very same way, we have a history and it might set me off, right? So, and I'm not even thinking about it. I'm not thinking about it. These are automatic pathways in our brain that you're going to have to redesign by becoming aware of them in the first place. So what I would say to you is that if you are interested in this kind of thing, realize there's a real science behind mindfulness and the ability to control how you respond to external stimuli. There's incredible benefit from it. It is moving out of the new agey kind of hokey area. A lot of companies now in Seattle are using it, you know, for their staff to get them more productive. It's actually been taught in some schools, teaching kids, especially kids with ADHD, how to use it to calm down. So I would suggest that in addition to taking my message today is about your diet, but it's also about stress. If you can find a way to modify stress over the long term, it's going to hold you in great stead. And so I've left you 5 minutes for questions. Thank you. Yes?
Are sweeteners like stevia and monk fruit as bad as sugar for you? And if not, do you know why?
So stevia and monk fruit, erythritol, there are a bunch of others, are natural sweeteners that don't stimulate insulin. And so that's why they've been put out there as great alternatives to regular sugar and then the other sweeteners, the artificial sweeteners that do stimulate insulin. So they don't have calories, but they stimulate insulin. And so, at least theoretically, they are better than sugar and the sweeteners. So I would say, yes. Here's the caveat though. There were studies done looking at them, and what they found was that even though they didn't stimulate insulin, the sweet receptors at the back of your tongue that pick up sweet, they still stimulate the dopamine pathway. So you're going to want to take more and more of these sweeteners, and so therefore you can become addicted to these natural sweets as much as you can to regular. And if you take too much of them, they probably do stimulate insulin, and they probably are not good for you. So what I would say is if you have to use a sweetener, those are probably the best ones to use. But I would caution from just using them as if with free reign. Oh, now I found my fix and I'm not going to have to pay for it. You probably will pay for it. So use them in small amounts. But I do think they are probably better than the other sweeteners. Yes?
Are these strokes related to anything to do with hereditary?
Yes, there is a small component, a small fraction of strokes can result from hereditary causes, and so especially strokes in younger people. Also, we know that a tendency towards atherosclerotic disease, the likelihood that you're going to have atherosclerotic plaques also can be inherited. So we've all heard the family who will have had heart attacks by the time they're 40. So yes, there are also some very scary genetic diseases that are associated with strokes. There's about 4 or 5 that I can think of, but they're very rare. They're very rare, and the vast majority of strokes are not related to they're not passed down. Yes.
Is there any effect of increasing fiber to help you reduce the sugars
Depends which book you read. Supposedly, the big benefit for fiber supposedly was that because of its bulk and then it's not associated with calories because you don't absorb the fiber, it makes you feel fuller sooner. Supposedly it can lower the glycemic index. It's been a mixed bag about whether there increases or decreases the risk for cancer. What I would say is that I actually see fiber as good, and the reason why I see fiber as good is not necessarily because of the fiber, but because it's where you find that fiber. The foods that have a lot of fiber in general are nutritious foods. So leafy vegetables, very nutritious, very high in fiber, and I think so. I'm not sure if it's the fiber itself. I think the question is not being completely answered yet. But I certainly would not be afraid of fiber as much as some of the other stuff we've been talking about.